I am really thrilled to introduce Dr. Mary Sano to present the next talk on Alzheimer's disease prevention clinical trials. Dr. Sano is professor of psychiatry, attending psychologist, and associate dean of clinical research at the Mount Sinai School of Medicine in New York City. She also is the associate chief of staff of research and development at the Bronx VA Medical Center and associate director of the Mount Sinai Clinical Translational Science Institute. We know her best as the director of the Mount Sinai Alzheimer's Disease Research Center, and greatly value her as a colleague in that network. And most importantly today, she has served as principal investigator on a number of truly critical landmark clinical trials in Alzheimer's disease. And maybe, well, at least for me, more importantly, she's done really incredible work about how we design and perform clinical trials, some of which I know she plans to share with us today. I personally have found her work to be truly guiding in my own, and so I'm so grateful that she would join us. And please join me in welcoming Dr. Mary Sano.
Well, thank you, Josh. As always, a kind introduction. But I'm very honored to be here. You have incredible speakers, but most interestingly, you have a very committed audience, and I think that's a very big deal. So let me begin right away. All right. So this is a slide I use frequently, and I keep thinking I should change it, but it says something that's so critically important, and I want to highlight it. We know that age is a real risk factor for aging and dementia. We know that the aging population is growing rapidly, and this is going to increase the likelihood of Alzheimer's disease. But there are two things I want to focus on, the last two bullets. We know that there's a period of mild and persistent cognitive impairment. It even now has a name. It has several names. It has MCI, or prodromal disease. And we know of this as a risk factor for Alzheimer's disease. But more importantly, we've been thinking that the change in technology in the world would make it easier for us to perform when we have these cognitive impairments. And what we know is that's not true. That even these cognitive impairments, we become possibly even more limited because the technology changes so fast that it can limit our ability to do everyday tasks, right? The way we pay our bills online can change, and unless we have maximum cognitive capacity, we're likely to be left behind. So I want to talk broadly about trials for prevention of dementia and of cognitive loss. So there's a few features that you've probably already gotten the message on. To do these trials, they're very large. In some cases, they're 1,000 or 2,000. In some cases, they're 30,000, depending on exactly what we want to look for and how early we want to go. And they're very long. We thought a 2 to 3 year trial would do it. Now we're talking about a 5-year trial with A4. And it's not unreasonable to think that when we're talking about dementia, that we would have to be talking about a 10-year trial. The other question is, what about the prevention of cognitive loss? One of the things that's interesting that I'm going to show you is in many of these trials, even individuals in the control group show some improvement depending on how we select them. So the idea here is that the treatment group, depending on what the treatment is, would require that we would see an even greater improvement beyond what naturally occurs, and that also raises the sample size that we need. So the challenge is big. Here's an example of a trial that is not a failed trial, as we heard a very nice description of earlier. It was a very clear trial because it worked just as we predicted. So this is a trial of Ginkgo biloba that included over 3,000 individuals who were selected. They had some cardiovascular risk, and we predicted the benefit based on what we knew would be the rate of progression. And what you see in this study is that there was no difference between drug, but the thing I want you to notice is the rate of progression from normal to dementia is very low. It's a matter of 2% per year, and these are in individuals who start at age 70. So it's a very slow rate. It means our numbers have to be very large. Here is another study. This is the PREDIVA study that recruited individuals with cardiovascular risk. And in this study, with people between 70 and 80, the intervention was a cardiovascular risk reduction approach. And what we're looking at in this slide is, again, the incidence of dementia. It was about 1% per year. So we know that if we take large cohorts of individuals and we follow them over time without any pre-selection, that the rate of cognitive impairment, or the rate of dementia, is slow. And so we need to think, again, bigger and bigger. Now, here's a study that shows the other problem that we have. This is the finger study results that was published in 2015. And the interesting thing here is we see a very small effect size. The cohort is nearly 3,000 individuals. But notice, this is cognition. Both groups are improving. So this is exactly the challenge of what happens when we don't have a selection on picking high-risk individuals. So the challenge for doing dementia prevention trials is choosing the right participants. And we've heard people reiterate this even in doing dementia studies. Selecting people who have a very specific and homogeneous type of disease will make it easier for us to predict how they will progress and to know how many people we need to move the needle and see a treatment effect. So the question we ask is, can we select a more AD-like decline, a cohort that's less likely to show that beneficial improvement? It's a big challenge. And when we're talking prevention, think of what it means. It means adding to your knowledge base another risk factor. Of all the risk factors that you deal with in your health care, here's another risk factor that you need to address. So the question is, how many do we need even when we do this, and how long do we have to engage them in the study, and what will make them stay? And that's some of the research I want to tell you about. So how can we select them? Well, we know, for example, that in the last 2 decades, we've realized that apolipoprotein E, the E4 allele, infers some risk, and it increases the likelihood of you're having an Alzheimer's dementia. So we know that, for example, individuals who have one allele are more at risk, and so that might be a population to select, or individuals who have 2 alleles and no cognitive impairment. We have an expectation that their rate of deterioration is going to be bigger. We also know that the amyloid load may have something to do with this. And we heard about the A4 study and the fact that we can now take individuals who are healthy but have some risk factors, and we find out that they have amyloid. What we didn't get a chance to show you is, what does that mean about their cognition? So just a reminder, what we believe is that the amyloid accumulates in the brain and can be imaged as much as 15 years before people have symptoms. And so what you're looking at here is the graph that shows us as amyloid, the increase of amyloid occurring in postmortem individuals, occurring much younger than the actual prevalence and onset of Alzheimer's disease. And here is just a scan using one of the early amyloid markers, showing that, in fact, normal healthy individuals can have a positive amyloid scan even though they have no cognitive impairment. But this is the reason why these individuals might be the ones we'd want to select. What you notice in this graph is the fact that even individuals who have, I want to see if I can highlight it for you in this particular graph, the blue line represents healthy individuals, older individuals who have no amyloid in their brain, and at the orange line, I don't know, does the pointer work? Is this a pointer? I don't know. Ah, yes, okay. Except I can only do one side at a time. Sorry about that. So what you see in this slide is that individuals who are healthy elders and have amyloid in their brain, I'm not even telling you that they're dementing, but over 3 years, what we see is a significant change in their memory scores. So unlike that group that I just showed you that had some cardiovascular risks, this is a group that's clearly at risk for Alzheimer's disease, and even though they haven't demented, what you're seeing is that their cognition gets worse. So that's why we're using our biomarkers to select these individuals, is because we know when we do select them, they're more likely to deteriorate. Now, the challenges of running clinical trials with these in this type of Alzheimer dementia is that we're looking for agents that are really disease modifying, but the benefit is really unlikely to be observed by the patient. So they're not converting here. They're showing a change on their cognitive test, but they're not necessarily showing any conversion to MCI. So this subtle change is one of the things that we need to target. The other thing to keep in mind is that cognition itself is really important. And so when we do those bigger studies where we have an unselected population, we're actually looking not just to slow a decline and keep people stable, but actually possibly to see a greater improvement. So we have technologies in place that can help us get this information more efficiently with, quote, lower manpower. But what I want to show you is that to keep people engaged in these studies, the human touch is critical. And every person on this stage reiterated what I have come to believe, so they know it and they've shared it with you. And I think it's also important to realize that the success or the lack of success, it's not a secret. We have some data, we have some information from these people. We may not have asked the question the right way, but if we listen, we can see that we're hearing from these people exactly what it is that they want and what will make them participate in a very committed way. Now, I wanted to talk about some of our misimpressions about clinical trials. When I talk about doing Alzheimer's disease research, and I talk to any of my friends who are clinicians, they just say to me, oh, you know, I have hundreds of patients who would be just right for you. And I think we always find when we're predicting how many numbers that we're off. And I think it's important to take a minute to ask ourselves why we're off so much. I think, first of all, the perception of a clinical population that's always overestimated has many people who are contributing to that overestimation. First of all, we know that as providers of care to our patients, that there's a clinical bond that's very strong motivator to ask people to participate. You as a clinician may believe this study is the right thing, and so it's easy to ask someone, you know, I'd like you to consider participating in this trial. And you heard many people said that they heard this from clinicians that they knew and worked with. But it's hard for a clinician, I'm not talking about the study clinician who knows exactly about the study, but it's hard for our referring physicians to understand the difference between the bond and the bother. And what do I mean by the bother? Well, you heard how much effort it is to participate in this study. Not to say it doesn't have great value, but for some people that effort may be just too much. And so we have to think about designing our trials to reduce that effort. And then the second thing that happens is doctors always focus on the inclusion. Oh, I have lots of healthy people who have family members who have Alzheimer's disease, but they never focus on the exclusion. Oh, well, I can't take anybody who has an implanted device or who has a little bit too much heart disease or whose hearing isn't very good because they can't participate in the studies. So we always focus on the inclusion, and that can create the perception that there's more people eligible than there may really be. And that's a challenge that we need to overcome. Now, there's some other reasons why what I refer to as the truly eligible can be different from the perceived eligible. And you heard a little bit about this earlier also. The commitment to an experimental approach may not be high. We had some really enlightened people here who understood that the value of the study is only there if we have a placebo control. And so we have to accept being randomized to possibly not getting the active drug. We have ways to overcome that, but not all studies have those ways. The procedures for standardization aren't always the same as the procedures in clinical care delivery. So, for example, the kind of intensive and frequent cognitive testing is above and beyond the kind of cognitive testing that you would get if you were coming in for your neuropsychological evaluation for a diagnostic reason. That, again, can create an unperceived burden. The idea of a placebo, again, I'm so impressed with the people we heard. It's a very complex idea, and while sometimes a patient may understand it, perhaps another family member doesn't understand it. Well, why aren't they just giving you that drug? I mean, that doesn't make sense to me. But you heard, we can't answer the scientific question without it. It's a hard concept to explain. And finally, we routinely underestimate adverse effects. They're really higher than recognized. It's not to say that they're not treated, but it's very easy. Many of us in the audience who do this research read these studies that say the drug was well tolerated, with 50% having nausea and vomiting. Yeah, it's real well tolerated by the investigator, but maybe not so much so by the patient or their family member. And it still may be worth the study, but it's important for us to observe just the fact that that may create another burden. So this is just a series of studies that I'm showing you, in which what you're seeing is with age, the number of adverse events goes up. It doesn't matter if the study's about Alzheimer's disease or arthritis or cardiovascular disease. We just, as we get older, our systems may be more likely to have adverse events at the same time we're participating in a clinical trial. So it's important to realize that. So I want to spend some time doing something that I think Josh has done a lot of work in that's really important. I want to share with you the voices of people who participate. And nothing is as clear as what we heard today, but there may be some more voices. We have some from people who chose not to participate. Important for us to realize what we have to overcome. I'm going to describe 3 studies. The first one sort of tells us how we select our message, what the decision-making process is for brain donation. This is some work that my center has published in the past. I'm also going to talk to a cohort that we assessed on the question of why do we stay? How do we keep people in the studies? It's so hard to find them. It's really important to make sure everyone stays. And then finally, addressing the burden. And I'm going to talk about that from a home-based assessment study that we added a research satisfaction survey to. I'll share the results with you, and maybe if we have a few minutes, you can tell me if they ring true. So this first study was one of our attempts to improve our brain donation in Alzheimer's research. And so we assessed individuals who are currently in our ADRC, and I did this work with 2 of my colleagues, Dr. Sewell and Dr. Nugrishel. And the idea was to improve this rate of interest. We assessed nearly 100 people, both participants and their study partners. And these were all individuals who had in the past said to us either no, I'm not interested, or they said, I'm unsure, you can ask me later. And so we had some open-ended questions about being approached, both personal and general feelings about brain donation. What do you think? What do you think others think? And the responses were qualitatively evaluated, and any response could go into more than one category. At the end of this period, where we just were asking people, we actually had 23% of the individuals change their status from undecided or from no to yes. So just asking, listening to the voices can be a really important way to engage all of us. So here are some of the concerns I wanted to share with you, and this graph is a little busy, but I think the dialogue is interesting, and also I wanted you to see how to read this. So this was the number of, this was the type of response, and here you have the number, and then it's patient and study partner is what the P and the SP is, and the kind of response that we got. So we classified them into this need for more information or a need to share and talk about it with family. People said, I want to discuss it with my daughter. Tell me more about the process. I'm not sure what it's like. I want my doctor or I want my family to tell me what they think of this idea. Now, there were other individuals who simply said, I'm not interested for religious reasons. I'm Jewish, or the body is not supposed to be anything but whole. In addition, there were people who had a clear reluctance to talk about it. It's not a pleasant conversation. The thought of dying is hard. This is at the early stages, but actually we found this to be throughout the disease severity. Someone responds, I'm healthy, I'm not ready to make this decision. And then there was physical concerns about body integrity. And for many of us, we were surprised that this was so important to people. But it's important to hear the voice and know what they're thinking. Well, I might need my brain, or I understand the benefits, but I don't really want my body to be altered. I want to die and take to my grave all of my parts. And then there were practical concerns. Well, how is it done? Will they drain it? How will you know that I've actually passed away? Now, those things may be things that we think we know the answer to, but it's the value of letting people tell you this so that you can address it where possible was really valuable. It really allowed us to know what information we needed to share. If we had not asked, our undecideds or refusals might never have changed. So, and then there was a series of people who had made a clear conviction. They made this change of mind. And here's some of the things that they said to us. Well, I'm planning on this changing my decision from no or from undecided to yes because I'm really ready to sign up. It's going to help my family. Or I know if my father really has AD, I'll get to share this with my family members. Now, the convictions are not all positive. There were individuals who responded to us, my mother was unlikely to do this, and I won't make this decision for her. I respect her decision. And there were also trust issues, which, as Josh explained, is one of the most important areas that we need to shore up in our research. If I were even hospitalized and there were a complication, would they come and harvest my brain? Well, we know that's not how it works. But here's a person who's in a very fragile moment, and taking the time to explain how it works can make a huge difference. All right, so I want to, as I mentioned, I want to go on to talk a little bit about understanding why individuals stay in research participation and why they continue for our many years in the study. And this was a smaller study. It only included 53 individuals, both patients and their partners, both participants and their partners. And we selected individuals who had done 2 or more visits, and many of them had done way more than 2. And we asked the question, we're interested in identifying reasons why research volunteers like you choose to continue participation over time. Can you give us some of your main reasons? And here's what these responses look like. Individuals told us, well, it really helps me take control of this thing. There's not a lot of things I can do, and this really helps me feel in control. Others, despite the fact that we work very hard to be sure there's no coercion, acknowledged, well, I feel an obligation. My wife, this is hard for her, but she really wants me to do it, and so I'm going to do it. Or my doctor's been taking great care of me, and they really want me to do it. So again, even though we've made all of these efforts at each visit to be sure they want to come, there is a sense of obligation. There were few, but not many, who said, well, it's free care, or in some instances, I got paid to come in. We often give people funds to travel back and forth, and they thought that was great. A very common response was, Alzheimer's runs in my family, and I'll know something more about this disease, and I'll have this value to give back to my family. Or altruism. I want to help defeat this problem. I want to make my contribution, an important aspect that you also heard about earlier today. And so just to give you a look, what I want you to notice is the obligation and the financial aspect are relatively low on these scales in terms of the percentage of people who reported to us that that was their motivation. The other thing that was really important is very high appreciation for the value of the relationship with the experts. The opportunity to talk to not just their doctors, but their coordinators, that value of the expertise, the contact, was very important to people. As well as the altruism, the very, very high from both patients and from caregivers. So I think it's important to realize that in recruiting for these prevention trials, we really have to think about our messaging. It's important to convey the need to do the research, to engage the empowerment that an individual has in making that decision. It's also important to realize that there's a burden involved, and informing the science and the commitment to staying in is hard, but there is a burden, and you want to be sure that you're honest about what the demand of the study is. And I think it's also important to realize that because you did it once, you're not done. Every day, my staff who sees my clinical trial patients, every day they get a chance to reinforce a thank you, how great a job you're doing. I know what a lot of work it is. So it's an important part of the message. And I think the other thing that we take away from this is it's important to listen. We often say, well, we have to educate them about the value of doing clinical trials, and we do, but it's important also to listen, to know what their understanding is. What do they perceive as a benefit? What do they experience as a burden? And so I want to talk in particular about listening to those voices in reflection of a study, a multi-center study that we conducted called the Home-Based Assessment Study. And this was a study in which we recruited individuals across 27 sites who were living without Alzheimer's disease, without any evidence of dementia or cognitive impairment. They were coming from the community. They could live in an assisted living, but they had to have enough independence to participate and to be able to be randomized to whatever choice they had. And we gave them a wide range of instruments. Now, the concept of the home-based assessment trial was to see if we could figure out ways to lower the burden by having people do the assessment in home. We thought that would be a great idea. Wait till you see what we found out. And individuals were randomized to 3 levels of technology, and so I think this is really another very important aspect. When people went out and talked about this study, their talks for recruitment all said, you know, and if you get randomized to the computer arm, we give you a computer and we hook up the internet in your apartment or your home, and it's all part of the study and it's all free. And the other 2 alternatives were to do mail-in surveys that you just checked off the list and you gave you an envelope and you mailed it in, and then we had a live person call you to do the cognitive testing. And the intermediate was something called interactive voice response system. And the way that worked was there was an 800 number that you called, and all of the questions were asked to you on the phone, and you either gave a vocal response or you gave a response on the phone keyboard. So you either got lots of paper and a person on the phone, or you got an interactive phone, which was a nice big phone with big buttons and nice high volume, or you had the computer kiosk installed in your home. So I mentioned the study features 27 sites, so this is a much bigger study than my local studies. We randomized over 500 individuals, and we collected the first baseline assessment, which I'll tell you about, and we assessed them cognitively, functionally, behaviorally. We asked them questions about their costs. That's what pharmacoeconomics about. We asked them some quality of life questions. Long study. People entered at age 75, and it was a 4-year follow-up. So 75 or older and a 4-year follow-up. And in the end, and in the beginning, there would be a face-to-face evaluation, but no one had to go into the clinic. So here's a little bit of what happened in the study, which I find sort of interesting. What you'll see is that we screened over 700, and we randomized 640 individuals, and then they were randomized to either the mail-in, that's what MIP stands for, or IVR, that's the interactive voice on the telephone, or the kiosk, which was the computer in their home. And so this randomization went smoothly, but then look what happened to the dropout rates, right? The dropout rate is relatively low in the mail-in with the personal phone call from someone, slightly higher in the IVR, and dramatically higher in the kiosk. And if you look down here, you can see that this made a very big difference. We actually saw people dropping out from the higher technology arms. I wanted to comment that all of the comparisons across those groups were significantly different. So, what do I have on the next slide? Okay, so here's what the group looked like. This is an important thing because when we're doing these clinical trials, we may need to actually enroll people who are older. We had individuals who were in their 80s, that was the mean age. We had people who had a lot of comorbidities. They had a history of cardiovascular disease and hypertension. And we actually recruited a very diverse population, which we're pretty proud of. I think that there were no differences across where people were randomized based on these things. So that was actually something we were pretty proud of. So the first thing we started to note was dissatisfaction with the technologies, right? Here we were giving away computers. We were like, everybody's going to love this, right? So the first thing that happened is we started getting complaints. Oh my goodness, they're so ugly. They take up so much room. The computer was supposed to remain on. It says, ugh, glows when I'm trying to go to sleep. And in terms of the phone line, people were complaining that there was a little bit of static on the line. That's because you had the opportunity to raise the volume. So there was, to our surprise, a little bit of more dissatisfaction than we expected. And what we discovered that in that early phase, after randomization, before we were collecting much data, we had a fair amount of dropout. So what we decided to do is at 18 months, we inserted something called a research satisfaction survey. This was a test that had been developed in clinical practice. It had 8 items in it. And then we asked them some open-ended questions to ask them about their preferences in terms of the overall experience in the study. So what did we find out? Well, first of all, in general, the people who answered our survey, and we even asked people if they dropped out of the survey, it was relatively high satisfaction. Most of them were more than satisfied. But the highest satisfaction scores, significantly higher, but only a little bit, were in the ones that were in the mail-in and a live person calling them to do the survey. And the lowest was in the IVR and the kiosk. So. Now, that's interesting, but I think some of these questions are really even more interesting. What we discovered is, by asking them 3 questions, what did you like most, what did you like least, and what would you have changed? And what's really interesting is how we reiterate what we already know, and we enhance with some new information. The most common what I like best was the volunteerism, that's the altruism. Also, they liked challenging and improving their mental function by participating in cognitive testing repetitively. And they loved the interaction with the study personnel, repeatedly stating to us that's one of the things that they liked the most. When it came to what they liked the least, I'm excited about the fact that about 1/3 of them actually said, this is not I didn't answer, but they actually said nothing. There was nothing that I liked the least. I think everything was good, but there were some complaints. They objected to tests, particularly tests that required repeating things over and over again, that had no variety in it. So it's something for us to keep in mind because you kind of heard a little hint about that can be disturbing. Maybe we can find better ways to assess cognition without it being too repetitive. They didn't like the repetitiveness of the visits. And they also didn't like feeling inadequate when things weren't going as well as they wanted. And that's a really important issue. As you're participating in the studies, if your capacity, if your abilities get a little bit slower or not as good, it's really important to find ways to be acknowledged that that can happen, but it doesn't necessarily mean that you're getting worse. It could be the normal change of aging, could be a slight change in disease, but it might be at the rate we expect. But reinforcing people when they're having a hard time and not just saying, oh, you're doing great, and sending them out the door, it might be a very important thing for us to keep in mind. And what would you change? Well, again, look at how many of them said nothing. I liked it all. But we did get some advice. A few things that sort of surprised us was we knew that they didn't like at all the change in the repetitiveness of test items. They did want to see that get more variable and more interesting. But they asked for more personnel contact, more contact with individuals who called them up, but they also wanted to see their fellow research participants. And the whole idea of leaving them at home was so that they didn't have to come in and be there, but we missed an opportunity for them to socialize. I think that's really important. And again, the comment that people asked about giving feedback. And you know, what we found is that even though the feedback that we cannot give them, how are you doing specifically, we can tell them how studies are going in general. And sometimes that feedback can be really reinforcing. You know, a new study came out today that used a similar method, and this is what they found. Really important to share right in the moment. So I want to talk about some conclusions and considerations. You know, participation in studies is really driven by many things, but it's mostly altruism. You heard that here, and you heard this across my 3 studies, right? It's really altruism. And these were open-ended questions, so they weren't prompted. They actually bring that topic up. Hesitation can really be driven by lack of information or lack of understanding or of the value of the work that's involved, right? The people in the brain donation, they just wanted to know more. What are you going to actually do? How does it happen? You know, what am I going to feel? And sometimes no is no. What I didn't point out to you is in our transition studies, those individuals who have religious and cultural decisions that make them say no need to be respected. Those individuals chose never to change their mind, and so we try to move on. We try to offer them other ways to participate in our research and not to push that topic. So the other thing to keep in mind is retention is really about delivering something that people want, whether it be information or a repeated conviction that they're doing a great job and they're making a significant contribution. I thought, and we actually heard, I think when Dr. Morris spoke, that there is clearly a preference for human over technology. Right? They sought out the people who could answer their questions. There are a lot of technical tools, but people often prefer to talk to a person. And I think that's an important thing to keep in mind. Also, asking about satisfaction can really improve participation. And asking before we begin may even be better because we can design with these things in mind. So I want to just take a moment to tell you some of the messages I hand out to people about participating in research. You know, low rates of referrals, what you heard was this is one of the biggest problems, low number of people who participate in research. And it slows down our clinical trials and our diagnostic development. And I think that for clinicians of any type, the concept or the thought of thinking about what might be available is really an important aspect for finding ways to keep those people who you've given everything you have to one additional opportunity. Not an additional opportunity to be sure they're being treated, but to be sure they're getting the most information and have the opportunity to make a contribution. You know, patients have many benefits and reasons for their participation in trials. And while altruism is very high there, so is the desire to get these evaluations and to have access to these medications at an early stage. But I think it's important to realize it's everybody's job. I think it's important for clinicians to know how to refer to research, for volunteers, with or without the disease, to discuss it with their families, to support a decision by a study partner. So if mom says, I want to do this, and you're like, oh, I don't know, it's a lot of work, I think it's really important to support the decision that individuals make. And I think it's important to support your mechanisms, what you know about funding for clinical research. And finally, I think it's important to realize, because this is where people can get very discouraged, not all studies are for all participants, and you can't always be accepted into a study, but making the effort is still worth it. You know, you heard today, the inclusions are about ensuring safety. Sometimes limitations by age or comorbidity can reduce whether or not you can participate. But it's important to choose a trial based on what you're interested in, who you're working with, and who you have trust in. And the way for that to happen is just to ask questions, and hopefully we'll answer them for you. And I can't stop without saying that I do nothing alone, and this is my team back at Mount Sinai who are involved in all my clinical research. So I'm going to stop there. Thank you.
So, UCI is home to this famous study of people in their 90s, the 90-plus study, great name. And one of the issues we've had is that we have an online registry, and we don't do a good job of helping support the 90-plus study yet with our online registry. And I guess maybe if you could make a couple of comments about your observations about, one, registries is a tool, because it's a new advance, and then, specifically, I agree with you, sometimes in Alzheimer's disease now we forget that a very large proportion of our patient population is 75 and older, and how are we going to do a better job of, especially recruiting the oldest generation who may not want a kiosk or necessarily be enrolling in our registries on their iPhones.
Exactly. I think this is really important. So there's a couple of things about technology today that I think can help us think about ways to be more successful with it. Have you noticed there's no such thing as a user's manual? It's supposed to come to you natively. Well, nothing comes to me natively, and so what do I look for? I look for a young niece or nephew to have them show me how to do it. But think about what engagement we can create, not simply by having those tools, but by engaging a younger cohort, not just to use them for them, but to show them how they work. I mean, this is a source of interaction, and it's also a source of being sure that people get registered and followed in a more efficient way. So I think that's one important way. The other thing that I think is important is once we learn the technology, the rate of change is so dramatic. I mean, the place where you do your banking, either on your computer or even in your ATM machine, every day that screen's changing, right? That's not a great thing as we age, to have to deal with those rapid changes and think about how are we, I just came here to get cash, and what does this mean about a mortgage? I don't understand. So I think moving as much as possible to some limited piece of standardization so everybody knows where to look to find a button that will help them move forward. So as you build technology or you introduce it, I think finding where it's stable is really helpful, but also expecting that it is going to change, and acknowledging that the way to make the most of that is to ask the person who's more experienced in it to consider engaging. It's a great opportunity. It's one of the things that we do with our, we have many volunteers who are in high school or in early years of college who want to do some first interaction with an aging cohort. And this is a great place. Let them introduce how to use some of these technologies.
That's great.
So.
Yep.
You mentioned at the beginning of your talk about donation of brain tissue after you die. My partner and I are both in our second Alzheimer's trial. And we signed up for Neptune years and years ago, before any of this occurred. Should the trial leaders know how we can affect donating a brain, even though we're signed up for Neptune?
So one of the most important things these days about research, tissue donation, and tissue collection is the expectation, most broadly, is that scientists will share what they have. And so, in fact, many of us who have brain donation programs, either in our center or attached to our trials, will also offer the opportunity to say, well, you know, I'm giving my brain over here. I expect you to share that information. And in fact, you'll often see that is a very big part of most of our Alzheimer's centers. Not only do we say, I'm glad to take your brain, but we will share it broadly with scientists in a lot of areas. And there's developing text in your consent forms, which are already really long, that say, I want to share this. I want as many people to use it as possible. So in fact, that is something that we're aware of. It's not always perfect, but we're actually developing more and more ways to share that information.
One last one.
Okay.
Comment on supporting the researchers?
Is that a question that's coming from a researcher? You know, I think that you're absolutely right. Supporting the researchers is important. And I think there's a couple of things right now that are going on that say that we're doing that. And first of all, the Alzheimer's Association has been pushing our legislative bodies to ensure that we have growing funding that will support research in Alzheimer's disease across the board, both in clinical trials, in training grants, in development programs, and that's a very important thing. And so as those things happen, our institutions are becoming aware of the fact that if we want researchers who can do this kind of work, they also have to join in that mission of supporting them. So it goes right across the spectrum.
And also, the part of it is burnout. You know, we lose a lot of people, I think.
I think that's absolutely true. And one of the things that we find is really important is understanding, and at least in my experience, all of the people that I work with, all of whom get paid a salary and all of whom have a specific job, they do above and beyond, and they do it in work that can be very tough, because as our participants are suffering, so are our workers in research. And I think it's really important that as we do these studies, we have room to support those individuals, to provide, first of all, there's a lot of self-support among each other. It's one of the main aspects of our center, is telling people, you never have to feel like you can't get everything done because there's always someone else here. And taking the time to appreciate the difficult things as well as the successes. So.
Really, really quick.
Okay.
Just actually a couple of comments. I'm an advanced practice nurse with more than 40 years experience, so my view of things is a little bit different. My mom had Alzheimer's disease and was in a clinical trial. My brother was her study partner, and it was so out of his usual scope, and he was proud of what he did, and it enhanced the relationship. And the other thing is that my mom would say, well, they're the only people I can talk to about what's going on in my brain, although she couldn't really get answers or, you know, that kind of thing, but she did feel the support, and that was very interesting to me and important to her. And the other thing is, every single touch matters, every single point of contact. And it sounds like your program is very full, and the volunteer component, I think, is great. So thanks for letting me talk a minute.
Thank you.
Thank you.
Thank you. Okay, that brings